I'm offering a new cognitive challenge just to keep us all healthy. I'm not using PowerPoint. I'm reminded when I think about long-term residential care of an interview I heard with the Queen Mother on the occasion of her 100th birthday. And she told a story of going into a nursing home and going up to a woman in a wheelchair and saying, "Do you know who I am?" And the woman responded, "No, I don't, dear, but if you go to the desk, they'll tell you." And I think of that, and you know, there are various interpretations, some of them not very nice, that you can make of that. But I think that it indicates that I think of it as dementia being a leveler of something that we're all at risk of, and that story really reminds me of. Like Tamara's presentation, mine today is based on a 7-year study funded mainly by SSHRC, titled Reimagining Long-Term Residential Care, an international study of promising practices, and a smaller one embedded within it titled Healthy Aging in Residential Places that is funded by CAHR and the ERA. Our objective is to identify promising practices for treating both residents and those who provide care with dignity and respect. We take seriously the advice of a care aide we interviewed who told us that while she didn't know how to fix it all, treating people as human beings, be they co-workers, patients, or residents, would be a good start. Our international team from 14 different disciplines and students from 6 countries has been doing statistical analysis and ethnographic studies for 5 years now. In teams of 14, we've studied 25 long-term residential care homes in Germany, Norway, Sweden, the UK, the US, and 4 Canadian provinces. And we have nearly 500 interviews, a host of documents, and an incredible number of field notes from those studies. Policymakers, employers, managers, unions, staff, personal companions, residents, volunteers, and families have all been interviewed for the project. We're seeking good ideas, trying to find ideas worth trying rather than proof or generalizations, but we are confident that we have confirmed 6 essential ingredients to dignified care, all based on assumptions that care is a relationship, as we've heard today, that care relationships are a critical component in addressing dementia, and that the conditions of work are the conditions of care. Some of these ingredients we've heard about already a number of times today, and the first, I agree with Tamara, not surprisingly, is staffing. Without adequate numbers of staff, it's hard to provide good care, or at least good care that does not wreck the health of those who are providing the care, as Janet was explaining in terms of unpaid care providers. Tamara talked about our research in Sweden. We have seen the same thing in Norway, the same thing in Germany. When there are lots of staff, it's much easier to provide good care. The atmosphere is so much more calm than it is in many of the Canadian homes or US homes we visited. The second is time, and again, Tamara reminded us of this. We have seen in North America a great deal of time being spent on paperwork, and that's simply not the case in Norway, Sweden, and Germany. That there we saw people having time to actually sit and talk with people, to respond to individual requests, to find out about people so that they can respond to those requests. And we did actually see people sitting and doing just that. Third, and related to both staffing and time, is continuity. It's not new news that continuity is important to those with dementia and that it's critical to developing care relationships, but we saw a growing reliance on agency staff, on part-time staff, on casual employees, and again, as Tamara mentioned at the end, in terms of labor, short-term labor from other countries, and we saw that actually in Sweden and in Norway as well. Yet we also saw places in Canada where there was a policy to avoid agency staff, offering additional work if necessary to those who prefer part-time work, and where staff was included in the decision-making in ways that included and encouraged continuity. And by this, I mean everybody, the people who work in the kitchen, the laundry, etc. Fourth is training, and again, this has already come up, but we heard about the need for training that is particularly relevant for developing care relationships, as Kitty was reminding us. In Manitoba, the home care providers, the providers who work in the home, all of them, had been trained by experiencing what it was like to go in a lift and be bathed. And one guy said to us, I couldn't believe how embarrassed I felt, even though they let me wear a bathing suit. Having had that experience, he said, gives me a completely different attitude to bathing other people. Also, we saw care providers respond, regardless of their status or their scope of practice or their job assignment, even if they then had to fetch someone else who had the appropriate skills. And we certainly saw this in an RN home, walking around with the director of care. We were interrupted all the time when she stopped to do something for one of the residents or one of the family members as we went around. And we saw the kitchen staff interacting with all of the individual residents in a Nova Scotia home where, because of the way the work was organized and the time provided, and that they were part of the team. Sixth, we've become increasingly convinced it's important to take some risks rather than focusing solely on safety. In Germany, for instance, the first thing we saw was a woman with dementia who was cutting onions. Getting advice from the other women with dementias on how to do this. This contrasts with Canadian sites, as I'm sure you know. We also saw in the UK, and this is my favorite, glass-fronted liquor cabinets on every floor, and people could get beer or wine when they wanted. And yet in Canada, we saw places where soya sauce was not provided to the Asian residents because it was thought to carry too much salt, and they would die from extra salt. And, I keep thinking of Goandi and let them eat chocolate cake, ice cream all day. So I think we have to move away from focusing so much on risk. So I want to end by talking about a particular program that we saw in Norway that was a music program. And it was a music program unlike other ones. Dot Pringle just said to me she'd die if she had to take part in some of the music programs she saw. The music program here, I think she might be interested in. It's integrated into daily life at a minimum of 14 points during the day. That their approach to music they argue, has dramatically reduced aggression and depression, wandering and shouting, socialization, and even obesity. I must say, when they provided the list, we got a little skeptical. But it has also virtually eliminated the use of antipsychotic drugs. On entry, they make a CD of the favorite music of the residents. And surprisingly, we heard most of it wasn't Goodnight Irene variety, but was ABBA and Black Sabbath and other kinds of contemporary music that they wanted to listen to and had available to them at all times in their rooms. But all staff is trained in music. Music's everywhere. It's used in the shower as well as in the sitting room, while giving wound care or dental care or where they're cleaning teeth. The lyrics from favorite songs are posted at the head of a bed. And when the care provider starts doing a personal care, for instance, they will start the song. And we asked to some of the immigrant labor that was there, who clearly didn't have Norwegian background, how do you do that? Do you know these songs? And they said, well, it doesn't matter. We can just start the words, and the resident picks them up because it's their song. It's the songs that they know. And I think perhaps what was most impressive is that they have a choir of people with dementia, many of whom are usually nonverbal. And this choir has been performing not just on a regular basis for other residents, but also for the town. And and we also saw music being used for dances, and at some risk, it must be said, as the rehab person said to us, yes, rehab is about taking some risks. Maybe they will fall when they're dancing, but they're having a good time when they're falling. So it's a low-cost strategy that seems to work for residents, for families and staff, but it's introduced against these essential ingredients I described. So in sum, there are alternatives, big and small, that it requires system change in order to allow those small ones to work. Thank you.